Yeah, so welcome, folks, to today's Young India Intensivist Sunday webinars in critical care. And today we are going to be covering mechanical ventilation, another episode in mechanical ventilation. And the topic is alarms and troubleshootings in mechanical ventilation. So the speaker today is Dr. Anup Kumar. Dr. Anup Kumar had taken one session on basics of mechanical ventilation, which may be familiar to some of you, and he's director of critical care medicine at Aster, North Kerala cluster, and he's a very regular speaker in critical care in our country. And I hope you all find it useful. Any questions, we will take them at the end. So over to you, Dr. Anup Kumar.
Thank you so much for this opportunity. Again, after a short break, we are going to discuss another basic concepts in mechanical ventilation. Actually, this is the final topic. To understand what is alarms and troubleshooting, you should have a basic idea about the modes, then disease-specific ventilation, and again, the basic concepts about mechanical ventilation as well. So after knowing all those things, putting together, and when patient is having some issues or when ventilator alarms are ringing, how we can analyze the issues with the patient or with the machine. So that will be dealt in this session. Rather than keeping on only pressures and troubleshooting related to the common ventilator aspects, we'll be covering bit extensively on different aspects about the clinical deterioration or other issues what we are facing during mechanical ventilation. So, as far as troubleshooting is concerned, we have to identify that there is a problem. Then that problem will be reflected as some alarms. You all might have seen, those who are working in the ICU, some alarms in the monitor or in the ventilator will be ringing. So these alarm settings are already done by the machine or by the operator for the patient safety. And this is actually to evaluate and manage the problem. So any good ICU where you are working, or if you are entering into an ICU, and if you hear unattended alarms, that means that ICU is not functioning properly, or the patients are not taken care properly. Because as I've already told, this is basically for patient safety. So whenever there is an alarm ringing, you have to find out what is the issue with the patient or with the machine, and immediately you have to interfere. The same way with the monitor as well. If the monitor is showing a low SpO2 or like high respiratory rate or variation in BP or some arrhythmias, all those things you should be able to detect. Then see what is the issue, and please don't use that 2 minutes silence button. So before using that, just find out what is the issue with your patient or with the machine. So that concept will be dealing extensively today. And as I've already told, whenever there is an alarm, we will be having a tendency to mute that immediately, whether it is a junior doctor or a bedside nurse. So alarm is not for that. It is for the patient safety. And in the alarm setting, as you are aware, if you go to the alarm setup, like different ventilators will be having different types of alarm settings. But when you go to that alarm setup option, you will be having different like alarm settings limit. Usually the P peak, minute volume, tidal volume, respiratory rate. CO2 usually won't be there, because to have a CO2 alarm, you should have an EtCO2 embedded in the machine. Then oxygen, then another FiO2, auto PEEP, then again the auxiliary pressure, etc. So these are the main alarms what we are looking. And during the initial assessment, you can set these alarms. We'll see how we are doing that. Or if you go to this auto limit settings, the machine itself will set in a way that the upper limit and lower limit are set at 15% below and above the present values. So these are the alarms on ventilator. And whenever you are using a ventilator, you should know what are the alarms in the ventilator, how the alarms are set up, and how to manage those things. So this is the auto alarm setting, which I have already told. Okay, so there are different things, and majority of the time we will forget to set the alarms on a ventilator, and there will be some problem with the respiratory rate, etc. when you are putting on the spontaneous mode. So that is also very, very important. Each mode wise, again, you can have a different settings, which we'll come to that later. And almost all ventilators, especially ICU ventilators, are equipped with visual and audible alarms, which notify the user the problems happening to the patient or the problems you are encounter during ventilation. So here, as you can see here, sometimes it will show that there is a low tidal volume. So this can happen because of many reasons. Maybe high airway pressures and you keep a peak very low in a volume control mode, or whenever you have a too much leak, or many decreased compliance, all these things can have a low tidal volume alarm. So the audible alarm usually it will be above 35 decibels. I don't think majority of us are checking the decibels of the alarm, etc. But still, for the theoretical purpose, you should better understand that. And rather, you should not keep it very high, and it should not affect other patients as well. So, what I'm trying to convey is even a small sound alarm, the bedside staff and the intensivist should be able to pick it up. And there are something like nurse-friendly button on the ventilator, which I've already told. It is a 2-minute silence alarm. It is not only there in the ventilator, in all other machines. If you are using an ECMO machine or if you are using a normal monitor or cardiac output monitor, everywhere you will be having that 2-minute silence, but better don't use that. Or you have to find out what is the reason why the alarm is ringing, as I've already told. Now coming to the alarm types. So you can divide alarm types into 3 different groups. The one is an immediately life-threatening types of alarm. One thing will be an electrical power failure. So here you should be very careful. Some of the ventilators will be having a battery backup. So even if there is a electrical failure, the ventilator will work. And majority of the ICUs will be having a UPS backup. So even if the power goes into a failure mode, the UPS will take over. But sometimes some of the ventilators won't be having a big battery backup, and even your UPS also sometimes go into a shutdown mode, which has happened in our ICUs also a couple of times. So that is why we should always have a standby ventilatory options like an ambu bag. And whenever there is an alarm, you have to immediately intervene at that point. And no gas delivery to the patient. Sometimes there may be like a disconnection of the oxygen that can produce this decreased gas delivery. Or sometimes if the central oxygen pressure is low, the FiO2 what you kept may not be delivered, and again it will ring the alarm in the ventilator. And if you are working in a good ICU, the central oxygen will be having a pressure alarm in the unit, and that will also alert you that the central pressures are very low. And this we were very careful, especially during COVID outbreak, especially in the small hospitals when you don't have a liquid oxygen, and majority of the time you are using bigger cylinders and the consumptions were very high. And there are electronic circuit failure, rarely happens. And sometimes you have a turbine failure. What is this turbine failure? The ventilator can work in 2 ways. One thing, you have a medical air and medical oxygen, and it is blended together, and the desired FiO2 is being given. Sometimes in small ICUs, etc., or in a transport ventilator, you don't need a like a medical air. Instead of that, there will be a turbine. So if there is a turbine failure, again, the delivering of the gases will be impaired. None of these alarms can be muted as well. Then there are potentially life-threatening alarms like high airway pressure, low airway pressure, high tidal volume or high minute ventilation, low exhale tidal volume, and other pressure volume asynchronies. This low exhale tidal volume, again, when it is showing, you should be very careful. Some of the ventilators will be having issues with the expiratory flow sensors. So flow sensor issue can also be reflected as something like a low tidal volume. So that also you should be careful. And there are non-life-threatening alarms like a single breath increase in pressure, high rate during procedure, oxygen cell calibration, etc., which are not that important. So you should be well aware about these life-threatening and potentially life-threatening alarms and how to tackle all those things. So usually the triggered alarms are like 150 to 350 per day per patient. It can be like a few of them will be actionable alarms, and majority of them will be non-actionable alarms. It can be false alarms or a nuisance alarms, like I've already told, because of sensor issues, etc. But as an experienced clinician or a bedside nurse, you should be able to pick up what are these actionable alarms, and you should be able to troubleshoot that alarms. And as you can see, 95% of the alarms in a ventilated patients will be non-actionable alarms. But five patients are actionable, 5% of the total alarms are actionable alarms, and you should not miss that. And alarm desensitization and fatigue is also an issue which I've already told. If you are not trained in detecting and acting on alarms, or not unit, if you are not setting these alarm properly, then it will be repeatedly ringing in all the patient bed, and you may miss an important event. There can be an impact on nurses and respiratory therapists along with the patient. There can be a sleep disruption, increased heart rate, increased respiratory rate, increased BP. All these noise disturbance can happen. But majority of us are already used to that setting. But still, as I've already told, if you're working in a good ICU, or if I am entering in an ICU, and if I hear like all the beds are having alarms and nobody is giving attention to that, I can just make out that that ICU is not properly managed. So as an intensivist, you should take care of that, and you should train your staff and juniors about this as well. Then there can be effect of noise on patients as well, like it can produce increased delirium, even increased effects of or negative effects on immune system, etc. And because of the delirium, etc., sometimes can have a increased length of stay. And even the many surveys have shown that these noise pollutions are having impact on patient satisfaction surveys as well. And there will be excessive workload, staffing issues, etc. Poor alarm design and setting is a main issue in that, and you should have a competing priorities in sorting out those alarm, and unclear delineation of responsibility, and no escalation plan and desensitization to alarms. So these are the all issues you can have. Then how we can manage alarm fatigue. So timely servicing of the equipment and avoiding that 95% unnecessary alarms which we've discussed. The calibration and testing of ventilator before use. So mainly majority of the time it may be the expiratory valve or the oxygen cell alarm which is ringing. That can be avoided by proper calibration and testing on the of the ventilator before use. So how we do that? Like if a patient is immediately coming to the ICU, you may not be able to do that. That's why what we usually does in an ICU is, right, there will be a crash bed kept ready where the respiratory therapist will check, calibrate, and use a test leg and keep the ventilator ready. So whenever you receive a crash patient, or even on a prior alert, if you are receiving the patient, there is nothing to hurry, or there won't be any equipment issues. You can connect that. This is most important whenever you are transporting a patient. So I've seen many times the ambulance people doing the calibration or testing on the patient, or if they come and connect the ventilator to the patient, then they'll realize the tidal volume may not be delivering properly. So that should not happen. The calibration and testing should happen before use and before each use. That is very, very important. And appropriate alarm settings are patient specific. There is nothing like a specific value, like you set a peak value like this, or you set a plateau value like this. Nothing like that. Depending on the patient situation, you have to properly set the alarms. And the staff education and training are the most important one. And you may not be there at the bedside always, and even your registrar may not be there at the bedside. So your bedside staff and RT should be able to pick up these alarms and the issues effectively. So along with learning the basic concepts about these alarm management or troubleshooting, you should go back and teach your ICU nurses also about these alarms, how to set and how to react to the alarms, or what is the significance of those alarms. That is very, very important. The same way, if you are shifting some patients on NIV through tracheostomy, so that sometimes we do that, the patient on ventilator for quite long time developing like ICU acquired weakness, where you are not able to completely wean off from the ventilator. We use these bypass machine through the tracheostomy. So at that point, especially the patients with the severe ICU acquired weakness or recovering patients with Guillain-Barré, C-spine injury, etc. So sometimes, like in the ward, the relatives or the bedside staff may not detect that there is a like a power disconnection, etc. And at the middle of the night, it can go for a complete shutdown and can have a severe deleterious effect for the patient. And sometimes we can even lose that patient. So wherever you are using these equipments, along with teaching how to set the basic the settings, you should teach them about alarm settings also. Clear and actionable alarm information should be passed, and a multidisciplinary team should be there to review and upgrade alarm protocols as per the patient. And interaction with the manufacturers to make alternation to improve alarm sensitivity is also very important, especially when we buy new ventilators. I think most of us might have experienced that during the COVID outbreak. Like we were not having enough the good imported ventilators, and we were depending on Indian make ventilators and had these issues. So whenever you face those issues with the newer ventilators or the new brands, it is better to interact with the manufacturers and give your feedback as well. So the main points to remember are: never ignore any ventilatory alarms, never mute the alarm unless you understand what is the issue, and never set the alarm limits very high so that they are not triggered at all. This also you will be having, someone will do this one as well. Like you keep the peak pressure, right? Or sorry, sometimes you can have these same issues like peak pressures, respiratory rate, or apnea time. Everything you keep very high so that there won't be any alarm. Don't do that as well. And like whenever your bedside staffs are sleeping or when they are feeling sleepy, if you do that again, you will miss all those important events which should have been picked up. Then sometimes in a future ICU settings, when you have like an effective tele system, etc. Nowadays we have these data output from the ventilators, monitors, syringe pump, etc. in all tele ICUs and the paperless ICUs. And I think some of you will be working in such ICUs. And there these data will be sent to the main station. And there the data management will be there. And there in the data management desk, in a control system, they will also be able to identify the central alarms, and they can even alert the bedside system, especially when you do the daily alarms. And the interventions are immediately sent to nurse, respiratory therapist, or doctor on duty. And even when you connect these to your mobile devices, especially for the remote monitoring, now things are possible where you can set these alarms, and whenever something goes wrong, then you will also get the alarms. Now coming to the alarm shooting, I've already told there are 2 minutes mute for all ventilators, and it will be basically uncovering the underlying derangement. So please don't do that unless understanding what is that. So whenever you have an issue, you have to check whether there is an issue with the patient, or is it an issue with the tubings, tubing disconnection, kinking, or like grease secretions, etc. The third may be with the ventilator. So any alarms can be because of these three issues. So you have to always start from the patient, see the patient is stable, oxygenation, hemodynamics are maintained. Then see the tubings, there is no disconnection, dislodgement, or kinking. And then come to the ventilator and see what is the basic issue. And you have to start it always from the patient. And the patient safety is the most important thing whenever you are troubleshooting any alarm. So the troubleshooting of a ventilated patient depends on whether there is a life-threatening hypoxia or there is a no life-threatening hypoxemia. So whenever there is a life-threatening hypoxemia, don't waste your time. Immediately you have to disconnect, then go with the protocol which they have already told. Then you will have to do the ambu ventilation. The same way when the patients are like having unstable hemodynamics, a minimal variation in oxygenation or your ventilatory parameters can also trigger a cardiac event or an acute or the patient can go for a cardiac arrest or arrhythmia. So you should be very you should be well aware about that. And how sick the patient, high ventilatory settings, especially when the patient is on a high PEEP, high FiO2, especially when you keep on 100 FiO2, etc., you won't be having any reserve. Usually, we won't keep it at 100% FiO2. We try to keep it always below 60. So at a 60 FiO2, high PEEP, that also means there is a high ventilatory requirement. Such patients can also go for life-threatening issues immediately. So you should give an extra care for such patients. So now coming to the first thing, like assessing such patients, like a 5 minutes challenge. So first thing you start from the patient, the troubleshooting, make sure that the patient is safe. In life-threatening hypoxemia, tube block or extubation, etc., try to secure the airway and maintain the oxygenation. And brain hypoxia is a time is our cutoff time. So whatever do you do that, as you can see this diffusion weighted imaging the patient with a severe hypoxic encephalopathy. So day before yesterday also I had a patient in my ICU referred from an outside hospital. The patient was out on the NIV, a little bit obese patient, GCS full. He had some secretions, developed an airway issue. They were not able to intubate, and he went into severe hypoxic encephalopathy. And finally, we had to withdraw the support. So that part you should be well aware. Or the whole concept about understanding this alarm, troubleshooting, everything is to avoid brain hypoxia. And your time is very precious in that point. You should not make any hypoxia that is leading on to brain damage. So there is a risk assessment for troubleshooting, like the level of hypoxia, the desaturation level, and SpO2. Suppose if it is at somewhere around 90, you are comfortable. 85 also it's fine that you have some more time. But when it is going below like 80, etc., there is a significant problem and you may not get enough time. And patient's condition can be managed with mask and bag and mask ventilation, or if the tube is already in position, you do the bag and mask. So the bag ventilation through the tube. Then there is a patient on organophosphorus poisoning, day 5 of feeding. The gases are stable, BP X-ray is normal. The patient is on a pressure support CPAP mode. You can see that 6 PEEP, 1 trigger, respiratory trigger sensitivity 25%, pressure support 8, FiO2 40. Now this patient is desaturating. So here again, the patient can go for further complications, and you have to see what is the cause for desaturation there. And if you assess, you can see this was the cause. There was a blood clot obstructing the tube. Okay, it may not be always a muscle weakness. That is why you have to assess the patient, the circuit, and the ventilator before taking any decision. But see this hypoxia. So the reason can be different. Now coming to a patient with a severe ARDS, as you are well aware, we have a PF ratio less than 300, 200 and 100. So this patient is very sick, PF ratio less than 100 with two inotropes. Patient is on a assist control, volume control mode. Still on a high FiO2, 80%, and 380 ml 1:2. Plateau showing 31, and respiratory rate is 28. And here also, it may not be always the lung issue. It can be like an equipment issue also. So don't think that whenever there is an hypoxia, it's all because of the patient-related factors. And here you can see the ABG wise, there is a respiratory combined acidosis lactase are also going. And in this patient, an ET tube exchange also will be a risky procedure. But if you feel that you are not able to pass the catheter, or if there is a significant resistance, you will have to somehow pre-oxygenate pre-oxidation also will be difficult because FiO2 is already 80%. So immediately you will have to change the tube. What we usually do in such situation is always start the patient is already on two vasopressors. Keep a higher dose of vasopressors and keep atropine, adrenal, everything ready. And either you can go for a tube exchange or you keep your other gadgets ready and do that immediately. And oxygen delivery to cell mitochondria to sustain life is a cardiopulmonary function. So the both cardiac and pulmonary. So I'm not going into all details about that. So here is that we have a 20-year-old asthmatic patient rushed to ICU. The saturation is only 70. She was intubated immediately on our assist control mode on 100% FiO2. PEEP was kept at 2, respiratory rate 12, IU ratio 1:4, and the inspiratory pressure was kept, the limit was kept at 25. The chest movement not noticeable, tidal volume generated is 150, and the patient is desaturating and hemodynamically stable. So remove and ambu, or you do something else, or you change the ventilator, or you are going to change the ventilatory settings. So here again, a patient with a severe spasm, like as you can see, your respiratory pressures, P peak will be very high. So any patients after, like especially the patients with spasm, on a volume control mode, if it is not generated properly, see what is the P peak measured and what is the alarm set you kept. So that is a one common thing which the mistake which we commit, especially during the transport without looking all those things. You just connect and the patient will get under ventilated and will go for severe acidosis and cardiac arrest. So you should be very careful about that. You have two options here. One is increase the P max. Another is increasing the peak flow rate, which is not there in all the ventilators. So majority of the time, increasing the P max will help you to deliver more tidal volume. And here I'm not going into the issues here. If the patient is already on a controlled ventilation, you can keep the patient even at 0 P. And even if the CO2 is on the higher side, never try to hyperventilate with a higher respiratory rate. Keep the minute ventilation and respiratory rate low and give more time for expiration. Along with that, you give the medical management, bronchodilators and other management also. So you can have a alarm drill practice also. That is also very important in an ICU. The same way, like the airway drill, cardiac arrest drill, the trauma drill, all those things should be played on a regular interval. And if you are practicing it regularly, you will become familiar with the skills and you will be able to work in a crisis situation. And there should be a role playing, like you can make a scenario like the one which I've already told. You can see how your nurses are reacting to that. Then based on that, by the time you are changing the tube, how others are like helping. What about the running nurse, your the airway nurse, the medication supporting nurse, etc. You can place them in different position, then go through the proposed scenario and see how they are acting. That is very, very important in developing a good system. And once you do like that, like whenever you come to a real situation, then they can immediately pick up that. And along with that, you should have a another important thing is you should have a like hemodynamic monitoring. Then 1 minute. And you should have an untitled carbon dioxide monitoring if possible. That can also pick up the dislodgement or disconnection easily. Then in the graph, you should be able to see the different pressures, and a bedside X-ray and an ultrasound will give you more clues whether it is a pulmonary edema or some pneumothorax, etc. So it should be a combined thing. You should have a clinical examination. You should see your monitors. Along with that, you should be able to see the ultrasound images, etc. So to interpret all those things, you should have a basic bedside diagnosis, what is happening. So to see like what is happening, your brain should be, or whatever things you are seeing, to understand what exactly is happening, your brain should have a, or your brain should be able to assess what is happening. Only if you are having a adequate knowledge about that, you will be able to do that. Then I've told hemodynamics and lateral carbon dioxide, the airway pressures are important. Along with that, see that chest X-ray and ultrasound are also an essential part of mechanical ventilation in an ICU. And along with that, you have to see the chest, you have to hear the chest as well. So this is the one which we always miss nowadays. All the junior doctors especially. See, to have a proper diagnosis about any case, you forget about the scenario, whether it is an infective case or a non-infective case. And history taking is very, very important. And again, how the sequence are like developing. If you have a bedside chart, like I've shown you previous situations. See how the hypoxia, whether it was gradually increasing, whether the pressure monitoring, whether it is gradually increasing. So you have to take a proper history. You have to thoroughly go through the charts and data, and you have to test the patient, feel the patient, and you have to examine before taking this ultrasound probe or any other investigations. Majority of the time, our junior doctors are missing that, unfortunately. Immediately when they get a patient, they'll be looking at cardiac contractility, poor literature, etc. That is fine. I'm not against that. But before that, try to examine the patient, come to a conclusion, make sure the patient is stable, then you go with your gadgets. That will be an ideal situation. And in this 5 minutes, you should have a clinical examination, see the chest, whether it is moving, hear the chest, whether the air entry is fine, see the ventilatory parameters, especially tidal volume, respiratory rate, the minute ventilation, inspiratory pressures, etc. See the SpO2 and EtCO2, whether it is properly there. And EtCO2 also, whenever it is connected, it can give you an idea whether there is any problem with the airways, which we can discuss later. And the third one will be the ABG, the blood gases, ultrasound, X-ray, etc. So don't jump into these conclusions initially itself, but in 5 minutes evaluation, along with all these parameters, you should not limit this also. I'm not saying that you should not use ultrasound, X-ray, etc. Then you are not fit to work in an ICU. But before taking these parameters, you should also use your clinical skills and other monitoring skills to see what is happening with the patient. So coming to the clinical examination, you have to see the chest movement, whether the chest expansion is there or not. Is there only a unilateral expansion? The tracheal tubing at the lip, that is also very important. So what we usually does is like the respiratory therapist after coming, we usually will be having round the clock respiratory therapist every day. Like they will come and see what level it is fixed, and that will be marked in the case sheet. The same way they will measure the cuff pressure. Along with that, they will measure the suction pressure also. That is the one which we usually miss. If your suction pressure is very low, obviously there will be too much tube secretion block. The same way, if you keep a suction pressure too high, more than 150, etc., that can produce severe bleeding also. So you should be very careful about those things. And the hearing the chest will give you whether there is a decreased air entry on one side, or if it is a mucus plug obstruction, or the tube has gone to one side, etc. And again, you should be able to make out these reduced breath sounds, etc. And I do admit that, like on a ventilated patient, even without looking at the V's, you can see that your airway pressures are high. But still, airway pressures can be high because of many reasons. So I still personally feel that the clinical examination also is having an important role in troubleshooting any such situations. Now coming to the ventilatory parameters, especially the graph, which we have discussed before, you will be having a PEEP. Then above the PEEP, there is a peak inspiratory pressure. Then there is a plateau pressure. The plateau pressure corresponds to the alveolar pressure. And the difference between inspiratory and plateau pressure, we call it as a trans airway pressure. And the difference between plateau and PEEP, we call it as a driving pressure. And nowadays, we are more worried about driving pressure, especially ventilating ARDS patients, and try to keep a driving pressure below 15. And as you can see, the different parts of alveoli, these things have been discussed extensively during the last session. But still, I'll give you just to refreshen your ideas. So this plateau pressure, basically the pressure in the alveoli, and the difference between inspiratory and plateau pressure, otherwise called the transient airway pressure, is the airway pressure. So, and the plateau pressure can be measured either by putting the patient on an inspiratory hold, or if you put an inspiratory pause, or in a pressure control mode, your peak and peak plateau will be same. And you have to always relate inspiratory pressure and the tidal volume, how it is changing. Uh, it can be because of a problem in the airways or tubes. It may not be always in the airway that you should be very. Peak inspiratory pressure and normal tidal volume means that the alveoli we don't have much issues. Then there are pressure relief or safety valves, which vents the gas out once the pressure is reached 10 centimeter above the inspiratory pressure. Usually we keep it at 40. That's again a safety mechanisms to prevent barotrauma. In an asthmatic patient intubated with severe bronchospasm connected to like volume control mode, sometimes an inspiratory pressure at 45 or 40 itself will give you high tidal volume, sorry, high peak pressures, low tidal volume, etc., where you will have to change it accordingly. So Tmax should be changed in those situations and make sure that the patient is adequately ventilated, but don't try to like achieve a tidal volume of 400 or 500 in that situation. Somewhere around 300 to 350, a minimal tidal volume or a minimal minute ventilation and a minimal respiratory rate with, or the whole concept is you give more expiratory time, which can prevent auto peeping and can improve the ventilatory aspects. So now coming to the other troubleshooting, like if it is not touching the baseline, here it is not very clear. This will be the baseline, and if it is not touching here, that means there is an auto peeping. So bedside nurse or intensively should be able to do that. And if you have the sawtooth appearance here, that means there is so much secretions. And here again, these part will tell you what is compliance, resistance, etc., and see whether it is triggering how effectively. And the expiratory tracings are show the missed breaths also, that can also be seen. And this is the plateau pressure depends on the compliance and the airway resistance. When the lungs are stiff, your compliance will be low. Whenever your compliance will be low, your plateau pressures will be high, or your driving pressures also will be high. The SpO2 and EtCO2 also are very important. Sometimes SpO2 lags behind the EtCO2. And the EtCO2 is having an inspiratory part and an expiratory part. The higher part is end-tidal carbon dioxide, and it is having an inspiratory, expiratory, and later again inspiratory. And this is again the different alveolar part and other parts. So depending on the issues and different parts of EtCO2 graph, we will be able to see whether there is an issue with anatomical desk space or alveolar space, etc. Metabolism is also very, very important, like hypothermia, fever, pain, anxiety, etc. can change the metabolism. A decreased cardiac output can sometimes lead on to complications. An increased CO2 may be a part of poor ventilation, and poor ventilation can be because of many other reasons other than the respiratory rate and other issues also. So EtCO2 will give you an idea about ventilation, circulation, and metabolism. So EtCO2 is an important parameter in that. So whenever there is a issue here in the alveolar part or the circulatory part, or when there is a issue with the metabolism, that can also affect different parts of EtCO2. And obstructed expiratory flow you can make out from the EtCO2. The leak also is easy to make out from the EtCO2, and EtCO2 other abnormalities also you can make out depending on the shark fin appearance, etc., the tube kink, all those things. So whenever there is an EtCO2, you should be able to see what is the difference, and you should be able to interpret, especially the leak when the tube is partially dislodged, or when there is an esophageal intubation, you won't be having any proper EtCO2 tracing. And whenever you work in an ICU, even if you are too expert in the airways, always make sure to use an end-tidal carbon dioxide assessment, at least during intubation. And with your cardiac output variation also, your EtCO2 will vary. That is why I've told it is a role in assessing circulation also. If your cardiac output is low, your EtCO2 can be low. Then sometimes we can have a significant difference between PaCO2 and EtCO2, especially when there is a problem with the vasculature. Your gradient will be too high. That can also give you an idea that it can be something like a pulmonary embolism. Ultrasound is also having an important role in troubleshooting, especially to find out there is a fluid or there is a the pleural sliding, length point, etc. And again, your B lines, which will tell you whether it's the lungs are wet or dry. Then your the seashore pattern again will tell you whether there is a pneumothorax or not. But what I'm trying to say is, and assessing like lung using ultrasound is also very, very important. And I missed one important thing in this slide. What is that? Now, along with these things, we are more worried about diaphragm assessment also. So, diaphragm assessment, the movement, then the fractional shortening, all those things are important, especially when you wean the patient from the ventilator. The pleural effusion, consolidation, all those things can be paid out. The trachea, whether it is inside the trachea also, it is easy to make out. The same way when you do the tracheostomy, whether there is a proper or a vessel is there, which you should avoid pricking. That is also very easy to make out with an ultrasound. And X-ray chest will also give you like a troubleshooting. You can see the pulmonary edema, ARDS, normal lung, the patient with a pneumothorax, etc. So X-ray chest is also very, very important. But don't think that you have to take X-ray every day. Usually, once the patients are getting stabilized, we will repeat the X-rays only when it is indicated. The daily X-ray concept is already out. You don't have to do that aspect. CT thorax has also a very, very important role as far as the ventilation is concerned, especially when your X-ray can't give you a proper diagnosis. The most important thing is in diagnosing the interstitial pneumonias, or when it is a non-infecting pneumonias, uh, or something like the drug toxicity, etc. Sometimes you can miss it with a normal chest X-ray or an ultrasound, but CT can give you a better clue regarding what is the mechanism of injury, or whether it is a pre-existing ILD, or whether it is a like autoimmune disorder, etc. So you should be able to interpret the basic CT thorax also. I think maybe if like our time permits in the later sessions, I would like to take a session on interpreting CT thorax also, because knowing to interpret a CT thorax is very, very important as far as an intensivist is concerned. And this is the most important equipment during ventilation, I will say. Even if there is an issue during the ventilation, you can manage it effectively. So all bedside should have a proper ambu bag, which is having a reservoir bag, other PEEP valve, or the pressure release valve, etc. So any issues, like you can easily come out with hand ventilation. But one changing concept is, previously during our post-graduation days and all, maybe 10 to 15 years back, even the patients who are severely hypoxic, the situation which I've already told, we were trying to ventilate the patient using bag and mask by keeping reservoir, PEEP valve, etc. I still remember this H1N1 outbreak and all in 2008, 9, that time. But from that point, now we have moved on to the pre-oxidation using non-invasive ventilation, or you put like mask connect to the ventilator and pre-oxygenate. That can give you a better oxygenation, even chest movement assessment, everything is possible. What I'm trying to say is, whenever you are trying to do so, you may not be having a proper ambu bag at the bedside. So make sure that all ventilated patients are having like a proper ambu bag. A clinical method of troubleshooting, I've already told, like life-threatening hypoxia, low life-threatening hypoxia, all those things you should be able to interpret immediately. In life-threatening hypoxia, the first thing you have to do is you immediately increase the FiO2 to 100%. See whether there is any disconnection in the tube or failure, or you change to ambu bag, and observe the patient for chest movement. And if still it is not working, disconnect and connect an ambu and oxygen. If SpO2 improves, it may be a ventilator tubing problem. Or if the chest start moving, it may be again some problem with the peak pressure adjustment, etc. Disconnect and connect ambu bag with the oxygen. If SpO2 does not improve, and if the chest does not move, then the problem lies below the ambu bag. It is a problem within the airway and the alveoli. You have to understand that. And the air leak is heard, or the gurgling sound heard in the ET tube near the vocal cord, outside the tube area, or in the mouth, if you can hear that gurgling sound, immediately you will have to reposition or re-intubate, and after proper pre-oxygenation, all those things. You should not wait until the patient develops hypoxia, and your EtCO2 will help in that aspect as well. If after connecting to the ambu bag, if you feel that the ambu bag is too tight, then some air goes in the chest. It is producing a noticeable movement, and ET tube suction, you are able to pass it easy. Then the problem may be below that. It may be the problem with the alveoli. Or if you are not able to pass it properly, and if your tube is tight, that means there is a problem with the ET tube. So he can be a tube kink, or sometimes, as you can see in the first picture, it can be like a mucus plug, or a like a blood clot obstructing that, or even sometimes your this clogged HMB filters can also increase the airway resistance. This is very important. You should all understand that. Like whenever you nebulize the patient on a ventilator, never use these HMB circuit. So if you sorry, HMB filter. So if you keep it before this circuit, all the humidified or these the vapors will be gets absorbed here, and the hygroscopic material here in this HMB filter, it will get clogged, and the resistance will increase, and even changing that will immediately improve the airway pressures. Sometimes you can have a low pressure alarm, like low tidal volume, low minute ventilation, or low expiratory volume, etc. It can be because of the leak. Leak can be there in the tube, or as you can see, if it is a like tube has completely dislodged, or if it is partially came out, that can also have a leak. The respiratory system issues, as I've already told, when the auto peeping is an issue, we can cause hemodynamic compromise and other issues. The triggering also will be an issue when patient is having too much auto peep. This will usually happen in COPD and asthma, which we have already discussed. And you can see that pleural line, see whether there is any issues with the pneumothorax, etc. And you have to see the chest wall, abdominal distension, obesity, etc. And too much abdominal distension and increased airway pressures also can be a problem during ventilation. That's why I've told you, like touching the abdomen or feeling and see whether there is no distended abdomen, or if there is a distended abdomen, decompressing that abdomen also is an important parameter. The DOPs you all will be knowing, like displacement, obstruction, pneumothorax, equipment failure, or like the stacked breaths. All these can be cause for high pressure. Then we will have to disconnect, connect oxygen. You have to check the tube, then tweak the ventilator settings and supervise with ventilatory graphics, EtCO2, sonography, etc. Double triggering or breath stacking can happen. Sometimes you can see the two trigger happening. It may be because of the improper set triggers. So, or sometimes it can be because of the high tidal volume and driving pressure. So you should be careful about that. The asynchrony can be either a trigger asynchrony or a flow asynchrony. See whether there is an adequate flow and the trigger is possible. If there is a delayed trigger or an ineffective trigger, double trigger, etc., you have to increase the trigger by 50%. And sometimes if there is an inadequate flow also, here you can see there is the flow is affected. In that case, you will have to increase the flow, or you have to adjust with the I ratio. The asynchrony in cycling, there is a early cycling and a delayed cycling. This is the proximal airway pressure, the conventional flow, and the pressure trigger. This is the neural inspiratory time, and there is a delayed cycle here. This is the patient inspiratory time. So here, with the conventional flow triggers, it may not trigger properly, but with other neural triggers, etc., it will be better to trigger easily, and the synchronization also will be better. The delayed cycling can also be because of trigger delay, trigger workload, etc. I'm not going into all these complicated things, but make sure what is the problem with the trigger asynchrony and why there is a trigger happening. Sometimes even a fluid inside the system can have a trigger asynchrony. The flow asynchrony, see this curve, and if there is a if this initial part is showing something like this, and that means there is no adequate flow. Here in the PV loop also, you can see this flow asynchrony or flow starvation. So that you will have to adjust with increasing the flow, or in the present day ventilators, adjusting with the I ratio. The flow starvation can be because of we have discussed the basic concept and now we are going bit advanced. Really sorry if you are not following that, but these are the basic things. Even if the initial part you are very clear, you can manage the patient reasonably well. But try to understand that. I think the lectures will be available in the YouTube even after this thing. So go back and listen to this again, and you can go back and read also to about these specific terms. In flow starvation, the problems will be in the volume control mode, the flow setting may be too low, or in a pressure control or a pressure support ventilation, the applied pressure is too low, or there is a long rise time, or excessive ventilator demand, or increased neural drive. So that is also an important thing. Like there will be excessive ventilatory demand because of the metabolic issues, or an increased neural drive because of any like CNS issues that can also produce flow starvation. And these tachypnea, please don't try to control with increasing the trigger. You will have to sedate or like you will have to use proper dose of opioids, etc. Then you have other take-home thoughts like you have to always respect your alarms. Do not mute or you do not mute. You have to correct the problem. Have a alarm fatigue correction program. Have a systematic approach in troubleshooting. Practice alarm drills. That is very, very important. You have to go back and do that along with learning what is the basic concept. Only four components to consider. I've already told, repeatedly saying patient, tubing, ventilator, and the circulatory part. So this is a 60-year-old diabetic, community-acquired pneumonia on ventilator, volume control mode, 50% FiO2, 480 tidal volume, PEEP 10, respiratory rate 18, then I ratio 1.2, sorry, 1:2, and the inspiratory pressure is 35, and it is showing a high pressure alarm. How do you proceed? So again, you have to see the patient, you hear the chest, immediately you make the FiO2 to 100%. Then moving reduce breaths breath sounds or they can be because of some obstruction there. SpO2C if it is coming down, immediately disconnect and then ambu ventilate. In the ambu ventilation also I've told you should use a reservoir bag, all those things. On ventilator again, if the patient is having a circuit catheter mount, if everything is normal, if your connections are normal, then the issue may be with the patient. Then you do the proper suctioning, it is easy. Then just next you have to see the HMV filter. Here also you should be very careful, especially for low tidal volume. These HMV filters will be having two caps. One connection is for connecting end-tidal carbon dioxide. So during intubation, your respiratory therapist may connect that and then they remove it and they will not put that cap back. So the air will leak out through that and your delivered tidal volume will be low. So make sure there is no leak around these HMV filters. So or in the monitor also you can see the percentage of leak. So that part I didn't stress too much, but the leak percentage also you have to see and you can set the alarms based on the leak percentage. Here again you can see that the kinking and increased secretions, all those things can have problems. Okay, so you have different other newer modes of ventilation also. So basically, you should understand the basic concepts about the ventilation, the troubleshooting, the alarm settings, and what all alarms to set. And to understand all those things, or if you have not followed any of these parts, go back and listen to the previous lecture about the basic concepts, different airway pressures, etc. Thank you so much.
Thanks, Dr. Anup Kumar sir. Very nice, and this is a very elaborate topic, and you have covered a lot of ground. And students are advised to kind of go over this when the video is up. So if there are any questions, please put them up. We'll try to answer. In the meantime, just a couple of things. There are so many things that can be said, highlighted. First of all, the most important thing is the apnea alarm out of all alarms, right? So one has to be very aware of this and very careful. And the settings for apnea alarm in most ventilators are default. Once the ventilation falls below a certain limit, you get an apnea alarm. But some ventilators allow you to put the settings for the apnea alarm, and these should always be in place. There should be a protocol for this. The other thing is the low pressure alarm, which is I think a very common alarm. And the commonest cause for this is a leak anywhere in the circuit. Sometimes there's a problem in the ventilator also, but that is the last thing. And one of the common areas where the leak occurs is at the cuff side. So after checking the tubings and all, everything is a leak at the cuff side. a very common thing that is done is change the tube. Okay, I mean, you check the pressure may tell, may not tell when you check the cuff pressure with your cuff pressure manometer, it may help you, may not help you, it's not always helpful. So a very common thing which is done in the ICUs, this is a study conducted over a 2-year period, and they saw that most of the times when the tube was changed, thinking the cuff was spoiled, the cuff was not spoiled. It was actually the tube which had come up a little and the cuff had come up a little, so it was giving a low pressure alarm. So always look for that, you have to do a laryngoscopy and make sure the tube has not come up a little. And clinically, how you can make out is, can just auscultate. Sir told you very much about auscultation. We don't do this. We just, do a lot of things, but we don't auscultate. Auscultate over the cuff area at the sternal angle with the neck. And if you hear a hiss, that means there's a leak. Normal sounds are vesicular over the properly positioned tube. Or if you're getting some frothing at the mouth or some little gurgling, so all that means that there is a leak. So that is very important. Don't just change the tube. Make sure that the tube is in place. You can just push it in, do a laryngoscopy, and that solves the problem. And this was a study actually, properly conducted study over 2 years. And the third thing is about nebulization. So when you nebulize, ultrasonic and mesh nebulizer are all right. They don't cause so much of a problem if you do it properly. But a lot of ICUs, we are still using small volume nebulizers or jet nebulization. So when you put the patient on jet nebulization, you have to be very careful because there can be a leak because you're adding an extra source. Very important is that there's an airflow coming in, and this airflow is continuous during expiration and inspiration. And if the patient's respiratory effort is weak, he can go into an apnea alarm because his respiration is weak and he has to draw air against this continuous source of air, right? So he's unable to trigger the ventilator, and he can go into an apnea. So the one has to be very careful. And the third thing is often there's a high pressure alarm because you're nebulizing and the nebulization goes into the expiratory circuit and hits the expiratory valve, occludes it, and there's a high pressure alarm. So there are a lot of problems with jet nebulization, and one has to be very careful. Patient can desaturate, go into apnea alarm. So all these things should be known and looked into. And please respect all the alarms. Don't walk away from the alarms. It's very important. Paying proper attention to the alarms and troubleshooting, understanding what is happening, looking at the charts, looking at the patient, examining fatafat. All these things are very important. There are a lot of things which can be said, but just a couple of things from my side. If any questions, we'll be happy to take them. Or if Dr. Anup sir has to say anything further.
No, I think we have covered almost everything.
Okay.
There are no questions also.
Okay, great then. I think we'll conclude the session. Till the next session by Dr. Anup sir. Probably he'll take a session on portable BiPAPs, small BiPAPs that we had non-NIV, and we'll take it after some time. So he has a wonderful series of lectures. So thank you, sir. Thank you so much. And I thank the audience for their patient hearing. Any questions, then you can put them always up in the chat box on the YouTube channel. Video will be up by evening today. Thank you so much.
Thank you.